All righty. Great. Glad to see so much turnout for this really, really exciting session that we have planned. Controversies in Calcium, an open-minded debate on approaches to nodular calcium. I see people sitting around the back. There are, I think, a little bit more seats if you want to sort of come in and try to find a seat. That would be terrific. We have just I think a spectacular panel here that really needs no introduction, but I will introduce them anyway. To my left, Ajay Kirthanay. To his left, Margaret Magintaggart, and then Rob Riley and Kevin Kroos, all expert coronary operators who deal with calcium on every day, and as I'm sure many of you are as well. And so this is really a challenging area for coronary intervention, nodular calcium. We're going to talk today about what are the challenges, how do we identify it, how do we treat it, what are the sort of different options, and then hopefully come together at the end and develop some sort of consensus strategy that we can all take with ourselves. So without further ado, Ajay.
Welcome, everyone. And it's funny because I was telling somebody before the meeting that we were going to do an hour session on nodular calcium. And the person said to me, "What? An hour on nodular calcium?" And yet the room is overfilled. So it's either that you all love nodular calcium or have to really struggle against it. There's free food, or you really like us, and hopefully it's all three. So I think with that, I'll start and talk a little bit about some of these challenges and talk about a case that I had recently in the cath lab that was very instructive in this regard. So I have disclosures related to a variety of research grants to Columbia and CRF. They're listed on the slide and in the app. I think first, it's really important to set the stage that we need to recognize that there's coronary calcium there. Interestingly, in randomized trials in whom severe calcium should have been excluded, in fact, it was a requirement in the trial, you still see severe calcification in 30% of cases. And with the types of cases that we see nowadays, this sort of CHIP population of cases, we can see severe calcification in up to 50% of the cases that we deal with. So this is a real issue, leads to struggles in the cath lab, it leads to quite a bit of pain during these cases. Beyond the initial pain of the case, though, it's also associated with increased procedural complications, edge dissections, perforations, and then later-term effects like stent thrombosis and even late restenosis. In fact, coronary calcified lesions are among the highest risk subset for subsequent restenosis, which is why we have to do a good job the first time around before they keep coming back. So specifically speaking of nodular calcium, the question is, what is this? There's this hazy lesion here. For a lot of us that do acute MI intervention, it could be thrombus sitting there, but actually with intravascular imaging, this is what a calcified nodule looks like. And we'll be talking a lot about this and the specific challenges this poses and potential solutions to it throughout the course of this session. So calcified nodules essentially are calcified spicules that sort of sit and protrude into the lumen. There are actually times when you'll see calcified nodules, but the lumen area is still preserved, but yet this can still be a problem. There's a couple different subtypes. There's just general nodules, and then there are eruptive nodules that have typical thrombus overlaid on it, and they're smaller fragments. And there's more thought and research going into subtyping these going further. Here is just an examples of it via OCT and then IVUS side by side, as well as the histopathology on the bottom. And I personally will confess that 10 years ago, before OCT, I thought of spicules of calcium, but I never really probably said the word there's a calcified nodule in this case. Nowadays, though, we're seeing a lot more angiographically, even though sometimes that can be silent as well. So how does it happen? You get increased torsional stress. The animation shown on the left is kind of illustrating what I'm saying. There's a higher prevalence of necrotic core calcium adjacent to it, and then you see this nodule start to come in and abut and encroach upon the lumen here. And it's thought to be due to fragmentation of plates or sheets of calcium as a whole. And I just want to thank James Spratt and the Optima team for some of these really nice videos that they do in a variety of areas. Nodules pose problems for balloon-based therapies. There's oftentimes you can actually get a balloon through them. Sometimes when they're really severe, you can't. But when you do, you get eccentric balloon expansion. You also have to try to push this aside, but sometimes all you're doing is pushing it aside. You're not actually modifying the nodule itself. And this has issues with regards to reprotrusion. It has issues with regards to deformation of the stent and beyond, particularly if it's an area of torsional stress. And so the case I will show you hopefully illustrates that well. Atherectomy can be used, but dependent upon where the device is and where the wire bias is, you may see that it doesn't reach the area of the nodule, and the subsequent talks will talk about this. There are other times when it can be quite effective. Similarly, if you have thrombosis superimposed, you can argue whether that might be somewhat of a contraindication to the use of atherectomy. So here's kind of a case that I picked to set the stage for this entire discussion. This was a gentleman who had an index procedure showing this thing in the mid-RCA. Also the distal RCA, is it calcium, is it thrombus? We don't know. We typically will image this in our lab to sort that out. Had very poor radial pulses, so we went femoral in this case, and also had severe disease, severe calcific disease of the LAD, which we were planning on treating in a staged subsequent fashion. Here's the OCT run that you can see coming back relatively fast. I'm just going to show you there's a lot of calcium. So when you have nodules, there's typically calcium associated with that. But then there's specific areas that are protruding into the lumen, like this. That's more of a stable calcified nodule feature. And I'll just sort of summarize this by showing you what it looked like distal, what it looked like proximal. And this is the hallmark of calcified nodularity, basically, both down here as well as in this mid-right coronary artery. So in this particular case, I want to actually ask everybody in the audience, if you see this, what would you do? Because we're going to ask you an audience poll of that in just a second. I'll show you what was done, and then, but I want you to think in your mind. Don't get influenced by what I show you. Just think, what would you do? Because we want to get a show of hands, and we're also going to see what it's like at the end of the case. So in this case, opted to do atherectomy, did NC balloons, deployed stents, large stents, post-dilated them adequately, got what I thought was a really nice result, was going to bring the patient back for a staged procedure of the LAD after that. Now, as is my typical practice, whenever I bring patients back for staged procedures, I always take a picture of what we recently treated because I want to make sure that I don't get into trouble on one side when there's a problem on the other side. This is, by the way, what the MSAs look like. Fantastic MSAs, good expansion with this approach. So if 2 weeks later, or 5 weeks later, when the patient came back for that relook, I think you can all appreciate in the mid-RCA, 5 weeks after the first procedure, there's this thing sitting within the stent. And this is actually one of the reasons why I do the relook, because it'd be nice to know that that's going on before you start intervening on the other side. So we did OCT imaging of this, and what you'll appreciate is there's stent, and this is in the distal area where you couldn't really appreciate it very well. There's nodule inside the stent, inside the vessel. Similarly, as you come back more proximally, here you have the stent. The expansion is great. There's calcium behind the stent there. And you'll see exactly in that mid-segment where that hazy area was, there's similarly reprotrusion of nodule back inside the vessel. Now, this is in retrospect. I didn't know what the heck this was initially, so I said, you know, heck, it's Columbia. I have a lot of imaging equipment at my disposal, so I'm going to IVUS it to see what's going on too. And so when we IVUS it, it's clearly calcium, and this is that area here, with reprotrusion inside the stent just 5 weeks after the initial procedure. So ultimately, opted to do NC ballooning, put Megatron stents in, got a very good result, pushed the nodule aside. We took the Megatron because it may have more radial strength. Remember, all of our stents don't completely cover the area you stent. There's actually only 16 or 12 to 16% strut coverage with many of the stents we put in, so that's why the nodule can reprotrude. And this is the final result we got, slightly smaller MSAs, but still big. And so this is the final, the angiography when we brought the patient back 5 weeks later to actually do the LAD, and it looks better. We did OCT it just to prove that it looked good. You start seeing some reprotrusion again, so this is one of the issues with nodularity coming forward. So that's kind of me setting the stage for these other great speakers who are going to talk to you about various techniques. But I want you to go back to at the beginning. When you saw those nodules, it's determined to be nodules, what would you have done? And so the way to answer this is to scan the QR code with your phone. You're going to have to zoom it in and do it. And we really want to get a sense from you of what you would have done to address those nodules from the beginning.
Watching the horses.
I know.
It was amazing.
Great. As this is at poll, you can see the numbers start to come up, but that's just a fantastic case of illustrating the challenges of nodular calcium, something that I think many of us maybe have never seen. I don't know that I've ever seen a case exactly like that, Ajay, so this is a terrific presentation. So Margaret McIntyre will be giving a talk on managing nodular calcium with atherectomy, the number 2 option on the screen.
Just let the poll finish. Okay, thanks for the introduction. So I'm going to talk to you about using atherectomy for nodular calcium, which I think for most of us in the room beyond the non-compliant balloon previously has been our main go-to therapy. So the concept of nodular modification with atherectomy, I think, has been that you're kind of shaving the nodular tissue down and reducing the volume of the nodular calcific plaque. And here's two examples from two cases I've done fairly recently. You can see the IVUS on the left before atherectomy, and then the IVUS still images on the right with the volume reduction after atherectomy. And as Ajay mentioned, we've got two options with atherectomy. We've got rotational atherectomy and orbital atherectomy. With rotational, you can have forward ablation technique. You can use variable speeds. You can use a kind of pecking, polishing motion. You can change your burr size, and you can change your wire to a floppy or a stiff. Despite all these ways to adjust your atherectomy, you can still have problems with your wire bias. So for atherectomy, with rotational atherectomy to be effective, you need favourable wire bias. You need the wire to sit against the nodule or the plaque in order for it to have its effects. And sometimes you can tell that from when you do your imaging up front, whether you're going to get favourable wire bias and whether atherectomy is going to be useful. One of the advantages of orbital atherectomy, in addition to the fact that it's bidirectional, it's going to modify the plaque as it goes forward and as it goes backwards, is that it has this orbital motion. So you're maybe more likely to get an impact on the nodule, which is a bit more predictable than possibly it might be with rotational atherectomy if your nodule's not near-occlusive. So just before I go on to show you the case I'm going to present, I just want to show you a wee bit of kind of recent data, courtesy of Akiko Mahara. So what we've understood recently from some of the OCT data from Disrupt is that with nodules, we often also have an associated calcified sheet, and actually in over 94% of patients, you'll have at least 180 degrees of calcium associated with your nodule. So it's not just that visible nodule you see, it's calcium in the wall adjacent to the nodule. And the other thing that's interesting is that, as Ajay also showed in the nice slides from Optima, that the nodule is not a solid rock of calcium, it's lots of fragments of calcium bound together with fibrin. And these nodules will either have a thick kind of fibrous cap, or they'll have an eruptive, more acute thrombotic cap. And those two types of nodules seem to present clinically differently and also seem to respond to therapy differently, and we're just starting to understand this. Okay, so the case I'm going to show you is a 75-year-old man just from last week. Presents with exertional symptoms, walking 2 blocks. He's got CKD, he's awaiting a renal transplant, he's diabetic, hypertensive, he's got increased BMI, he's got spinal stenosis, and he's got non-invasive imaging showing a medium to large area of defect in his infralateral wall, and he's got an LVEF of 51%. So he has an attempt at this right coronary artery at an outside hospital. They failed to cross the second lesion with a wire. And gave him 5 gray and lots of contrast despite his CKD. So he was transferred to us fairly shortly thereafter to see if we could tackle this near-occlusive, what appears angiographically to be nodular disease in the proximal and mid-RCA. So it was actually pretty difficult to cross this. So we had a supportive microcatheter, an AL guide, and a 4-gram polymer jacketed CTO type wire. And eventually you'll see, as I go through the pictures, eventually we managed to negotiate our way through, but actually you'll see in this picture on the left, it almost looks like we're subintimal. As the wire comes round, that severe calcium in the bottom bend of the right coronary artery, but managed eventually to cross, have to actually take a guide extension in to help me get the microcatheter to follow, and we exchange out for the rotowire. We then proceed to cross all that disease with a 1.5 burr fairly successfully. So this is obviously at baseline when the disease is so critical. I'm not going to image or be able to image. So this is the IVUS after the 1.5 burr. And what you'll see as we come through, and as you can see in the 2 still images, there was 2 areas of nodularity. The one at the bottom is the one that was the more critical lesion, more distally, and the one at the top right was the nodularity that you saw more proximally. So then what we did was we took a 3.5 non-compliant balloon, and you'll see that I've deliberately taken contralateral views. So even after I've modified calcified nodules, I'll always take a 1-to-1 non-compliant balloon size with imaging and look in 2 views to make sure that I've got adequate balloon expansion before I'll stent. Then implant a stent. I then repeat the IVUS, and you'll see here some of the modifications. So you'll see in the bottom right-hand side, we've got some modification of that more distal nodule, and you'll see on the top right-hand frame that we've got a fracture in one of the areas where there's more concentric calcium. So I then need to use balloon anchoring to get the guide extension right down distally around that bend in the right coronary artery, eventually to get the stents down, and use this kind of deliver and unsheathing technique using the guide extension. And we implant a 4038 drug-eluting stent, post-dilating to high pressure with a 4 non-compliant balloon, again sized from the imaging. And this is our final stent result. So on the left, you'll see the stent result. On the right, you see the disease that you'll see in a second more proximally on the angiogram. So stent result looks good. The distal end looks fine. There's no significant plaque burden. There's a bit of eccentricity, but the stent areas were 10 millimeters squared as we came up through that huge right. You'll see at the proximal end of the stent that I've got a fracture in the concentric calcium that's very localized, which I was actually happy to leave behind. It'll be interesting to see if the rest of the panel would agree with that. And you'll see that proximally there's some non-obstructive disease, and there's also some minor nodularity you see right at the very proximal vessel that comes in on the right-hand side here at the end. So this was our final result. So we used low fluoro, which is why the images are not as clear as you might normally be used to, with 7.5 frames per second because of his recent high radiation dose. And we only used 10 mils of contrast, one picture at the beginning and one picture at the end. You'll see his minimal stent area at the end was 10.1. And the proximal MLE, which wasn't stented, that area you can see angiographically was nearly 9, despite the kind of eccentric calcific plaque. So just to show you some data from Glasgow that we had collected before. So we looked at 765 root ablation cases we did over 5 years, and we were particularly interested in complications, short and long-term outcomes. And what we found was actually, despite the very effectiveness of rotational atherectomy is associated with significant complications. So you can see at the bottom there a procedural NACE rate of 15% in women. And 9% in men, and that breaks down largely into tamponade and dissection and other bleeding complications. So to conclude, atherectomy is an effective technique for managing nodular calcium. It's preferred initial strategy for me still in very large nodular protrusive masses. Rotative for me is preferred in the uncrossable lesion. Orbital I think is useful if you get very large lumens or precarious hemodynamics. Both techniques do require a period of training. You require, if you're dealing with bifurcations, you require to be comfortable with a single wire technique, particularly in the left main, and not to be anxious about not having a wire in either the LED or the circumflex if you're having to use it. And despite the utility of atherectomy, we have to accept the fact that it is associated with an occurrence of full limit and dissection, embolization, and unfortunately in some cases perforation. Thanks.
Thank you, Margaret, for that terrific presentation and expertly handled case. So the format of this is going to be, we're going to save our discussion and questions for the end, and so we'll move right on to managing nodular calcium with a different approach with IVL and Kevin Gross. Kevin.
Thanks. Welcome, everybody. Glad to be here today. We're going to talk about managing nodular calcium with IVL. I'm going to go through this pretty quickly because Ajay and Margaret had reviewed some of it before, but there are potential limitations to many therapies for treating nodular calcium. I think both of the cases have been showed so far highlight some of the challenges with dealing with this clinical entity. It's well recognized that nodules treated with atherectomy result in worse long-term outcomes compared to non-nodular calcium treated with rotational atherectomy, higher rates of MACE, TLR, and stent thrombosis. And so thinking about that, shockwave is a very different mechanism. And obviously the mechanism of the balloon is to go in and create shockwaves which are able to modify both near and deep calcium. And this potential has a different mechanism compared to our shaving technology, such as ROTA and orbital. If you think about that, the mechanistic advantages of shockwave in nodular calcium potentially relate to the fact that it selectively targets calcium, unlike non-compliant balloons. It's able to modify deep calcium. That has some relevance with regard to the biology in terms of the plates that are often behind these things that were mentioned previously. And it really is independent of wire bias, which varies compared to rotational atherectomy, but could be similar depending on whether you're comfortable using orbital atherectomy, as Margaret nicely highlighted. And really, this is able to be sized up to 4.0, which is helpful, because a lot of times these things, we find them in large proximal vessels, as seen in the right coronary arteries, and also seen in the ostial circumflex that Ajay showed earlier. And so thinking about intravascular lithotripsy, it's able to create these microfractures in calcified tissue in a circumference. And this is able to both affect near calcium and deep calcium. And so in order to affect calcium deep, your rotational or orbital atherectomy burrs have to touch it. And so there's potential to affect deeper calcium. And given the plates and the anatomy of how these nodules occur, you can potentially impact calcium deeper in the tissue than just at the place where your atherectomy burr, either roto or orbital, may contact the tissue, may contact the nodule. So really, IVL has been shown to be successful, I think unexpectedly, in treating nodules. This is one of the goals of our cases. You'll see pre-IVL, there's an eruptive calcific nodule. After IVL, you'll see deformation of it. And we like to see concentric expansion, as shown in the panel on the right, with fracture of the nodule. This is the case we aspire to. Unfortunately, these entities are difficult, either with mechanical atherectomy or with IVL. And you don't always achieve that, but you do achieve good concentric expansion a large part of the time. If you look at aggregate data from the shockwave experience, in the percentage of times you get perfectly circular versus slightly deformed stents versus eccentric expansion, you get concentric expansion with nodules in up to 77% of cases, which is great. And so you tend to get more circular stents than you do in these cases where it's slightly deformed. And aspirationally with these things, we really like to have the geometry of our stent be a circle or an oval and not an indented heart shape, because we know that these latter ones are associated with worse outcomes, higher restenosis, and potentially higher events of thrombotic stent events. And so with that in mind, IVL in clinical studies has really given us a highlight that it seems to work with regard to minimal luminal area, minimal stent area, and mean stent area, with the dark bars being non-calcified, and then the lighter blue bars being calcific lesions. Additionally, at the area with the maximum calcium signal, the MCS, you'll see that there tends to be very, very good stent expansion with areas that have the highest amount of calcium and nodules in these studies. And so I think quite nicely we've been finding in recent data and in recent experience, there's a value to IVL in terms of getting reasonable results with what we know is a difficult clinical entity to treat. And so, furthermore, I have a couple cases which orient us, but before we get into those, you can see looking at the nodular calcium outcomes with IVL, they look very good, and they actually look better than some of the historical studies of looking at rotational atherectomy. So we know that calcific nodules are more difficult to treat. It's not surprising that the TLF, TVMI, and there's one stent thrombosis rate, one stent thrombosis event here, but you do see a little bit of a worsening of outcomes, which is not surprising given what we know about these entities. But overall, the outcomes look very favorable compared to other technologies with treating this, and actually seems to be tracking quite well with getting good stenting results and durable fixes for patients that have these. And so with that in mind, I have one high-risk PCI case which was managed with shockwave in the setting of a nodule. It's a 73-year-old gentleman, class 3-4 angina, 3-vessel coronary disease, who underwent a heart team evaluation, was turned down for poor surgical targets. His PET showed global viability with an EF of 20%, and the plan was for complex PCI. Pre-PCI right heart catheterization showed an elevated wedge, a low cardiac index, and we plan to do Impella-assisted high-risk PCI in this situation. The referral angiograms are here. The left dominant patient. I'll let this play for a second. By way of summary, there's a tight OM3, quite substantial in this left dominant system, an OM1 CTO, and shown probably better in this next angio, there's also an LED CTO highlighted here. And the right coronary artery, which is non-dominant, also had substantial disease. So by way of summary, it's a left dominant system with an LED CTO, an OM1 CTO, and an OM3 occlusion of 90% with calcium throughout the entire coronary tree. These were the PCI setup shots we took. You'll notice that the left circumflex disease had progressed in the month that it took him to get to us. And so we really wanted to focus on opening the left system first because this was a single open vessel, and we were going to turn our attention to the OM1 and potentially the LED, and we decided to stage this procedure because of the contrast load that we used during the first case. And so we went ahead and were able to wire the OM3 with an antegrade wire escalation strategy. You can see that after predilation, the IVUS shows a substantial amount of concentric calcium. There's a small nodule there. And this is something for discussion, I think, afterwards. A lot of times in marginal low EF patients, especially in the single remaining vessel, it's nice to be able to avoid atherectomy because, as Margaret outlined, sometimes the risk of embolization can make the patients more sick during the procedure. And so with Shockwave, we potentially are going to embolize less, and that has some value proposition potentially in these high-risk MCS cases. After we were able to do Shockwave throughout this entire segment and got good compliance, I'll often test the lesion with a large and long 1-to-1 size non-compliant balloon to make sure there's no waste. As Margaret does, I'll sometimes spin the II just to make sure that there's not an eccentric nodule I'm missing. And if there's any question, you can actually do intercurrent IVUS imaging to make sure that you've had adequate lesional compliance. The lumen is growing on the IVUS is the best way to see that you've had a good result. So with that in mind, after distal stenting, we were able to wire and open the OM1. It was a small vessel, so we left it with a balloon angioplasty only result. We brought the patient back about 14 or 18 days later and did a stage PCI of his LED target. This was done with a little mini star where we went subintimal for a short distance and then re-entered using a Mongo knuckle wire. You can see here the IVUS again shows substantial calcium, large nodules. This is treated with pulses with a 3.5 millimeter Shockwave throughout the nodular and calcified segment with good release of an NC balloon afterwards. And IVUS-guided reconstruction led to overlapping stents and greater than 80% expansion with only a small amount of eccentricity in the area where the nodule was. So by way of summary, IVL offers mechanistic advantages in nodular calcium. You can get fracture superficial and deep calcium. It's independent of wire bias. Studies start to show us that there's good MSA and stent expansion despite nodular calcium, and the nodular outcomes look promising at 1 year. Thank you.
Great. So another terrific case, that one managed by IVL alone. So we've seen atherectomy alone, we've seen IVL alone, and now Rob Riley is going to come talk to us about managing calcium with both the combination of atherectomy and IVL. Robert.
Fantastic. Okay, good afternoon. Couldn't quite remember if we crossed noon yet. Good to see everybody. So I get to overlap the atherectomy and the IVL part. So you get a little bit of what you've already seen, a little bit together, and just so we're clear, I won the poll, so this is going to be the best talk. So let's get your clickers ready.
It can only go down.
That's what it was. All right. So these are my disclosures. So we've talked a little bit about this, right? What is the deal with calcified lesions? Well, it's a vascular compliance issue, right? That's the reason why treating these lesions leads to an increase in major adverse event rates. All the things we have to do to prep the vessel that are different than our non-calcified vessels. And then once we get a stent there, the underexpansion associated with, again, because of this decrease in vascular compliance. Nodules are no different, right? Again, a non-compliant area coming into an area they were trying to prep to get a stent in. And again, it's this compliance that really is at the bane of our existence of treating these lesions. Again, very similar to what you've seen earlier, all of the things we do to try to prep these in our conventional calcium toolbox really have limitations, whether it's balloons, NCs, specialties, et cetera, which really go towards the more compliant area, right? They don't really modify, per se, that non-compliant area, particularly nodules. We try to maybe score them, maybe fracture them. And atherectomy in the same way, we maybe try and get a stiff wire in and bias it over towards these nodules. But again, these technologies are not meant to change compliance, which is at the core of our issue with these lesions. As presented just a minute ago, even with nodules, when we use atherectomy, we still have a big delta between events for those with and without nodules. So again, traditional technology has not closed the gap. But when we look at the intravascular characteristics of these nodules, most of them are associated with big arcs of calcium, as we talked a little about earlier. And what do we know about big arcs of calcium? We know that IVL should work, right? And the data that Kevin just showed you showed that for our calcified nodules versus non-nodular lesions, IVL results in the same intravascular imaging characteristics in terms of MSA and other characteristics that we know lead to and predict outcomes for our patients. So again, if we can get our IVL there, we can potentially close this gap. So what about if we can't get our IVL there? And that's this idea of using atherectomy in combination with intravascular lithotripsy, rotoshock, whatever you want to call it. The idea is, again, atherectomy in order to deliver our intravascular lithotripsy. What do we know about it from the data? Nothing. There is no data. There's some cool case reports, there's word of mouth, and there's sessions like this. So let's not talk about data because it's just not there. But we do have best practices that we can talk about as we build a repository of data moving forward. So very similar illustrations that you've seen because most of them are from Optima. So again, we thank Spratt and the crew, really good illustrations for these talks. So what do we do in the absence of data? Again, we talk about expert consensus and talk about ways to build consensus in that regard. So with that, we'll look at a few cases that illustrate how we can use atherectomy in order to get our IVL into these severely nodular calcific lesions. So here's a fun case. This was, I think, 2 months ago, something like that. Anyway, 82-year-old comes in inferior STEMI. You can see it's a left dominant system. You can see the culprit lesions in kind of the mid to distal dominant circumflex just proximal to the LPDA. But surprise, surprise, there's some fun zone in that distal left main that maybe extends into the prox LAD. Lovely, lovely STEMI to start your evening off with. My partner was on call, goes in, decides to stent the mid to distal circumflex with a 225 long stent. Had a very tough time getting it in there, a lot of guide extension, double wire, et cetera. Able to slide that sucker in there, expand the stent to a degree, walks away. Now, that walking away is somewhat unfortunate, right? Why is that unfortunate? Well, one, you put a 225 stent in, couldn't image because you can't get an imaging catheter in there. Two, you've left pretty bad inflow disease, right? It's not great for a fresh stent. Patient goes up to the ICU the next day. Hey, is Rob here? Sure. Can you go see the patient? Sure. CT surgery's up there. CT surgery says, hey, listen, you're 82, you had a STEMI, not super interested. Great. So I come over, hey, how you doing? Okay, you clearly have an indication for PCI, I can help you out. Tomorrow afternoon, boom, I got you booked out, we'll do your case, right? About 30 minutes later, I'm up in my office, I may or may not have had coffee brewing, and I get a call from the nurse in the CCU. Hey, just so we're clear, as soon as she walked away, STs went up and the patient's having chest pain. I said, hey, it sounds like maybe we need to move the procedure time. What do you think? She said, yeah, how about now? So take the patient back to the lab. Everybody knows what happened, right? We had acute in-stent thrombosis of that circumflex stent. Why? Because we have an inflow problem that wasn't fixed and we have an undersized stent. So now we have a problem, right? And yes, I went femoral, horrible person. We've just been stuck radially. Anyway, here's the problem we have in this case. I'm trying to get down the circ. I can get a wire down. Nothing else will go. I don't know what's happened to this nodule, but nothing will go. So we got to do something to that inflow problem, right? So what I do is I end up taking a wire down the LAD and shave off that nodule. Now, thankfully, during the rotational atherectomy, probably just the heparin being on board for a little bit, the patient starts to stabilize out. Chest pain's getting better, hemodynamics look okay, STs are starting to look better, so we have a little bit of time to figure out what we need to do and do it right. At this point, we still having a hard time getting anything down the circ, so we image, and sure enough, there's a fun zone nodule just sitting right there. And we've shaved a little bit off of it, but again, still big residual issue there that's keeping us from getting anything down the circ. So we try some INSEE balloons, then we try a Wolverine balloon that wouldn't cut it, and you're welcome for that pun, and you can take that with you for the rest of the day.
It's a dad joke.
So, whenever I'm a dad now, I do what I want. So the Wolverine wouldn't do it, so we take a 1-to-1 sized IVL balloon in, a 4.0, and one of the things about nodules that you'll find is that oftentimes in our circumferential calcium, we'll get good expansion of the balloon, 20, 30 pulses, sometimes even 10, right? Our nodules seem to really take sort of the end there, 7th train, 8th train, really getting to the end up to our 80 pulses to really get good expansion. About 70 pulses in, we finally get reasonable expansion, see fractures by IVUS. So at this point, we're able to go in, IVUS the circ, pull it out to its proper size, stent the LAD back into the left main, get a pretty decent MSA based on the Excel trial data there in the left main. Case number 2. Patient was, this was, a couple weeks ago, I think. 62-year-old guy, outside hospital, end-STEMI, left main is diseased, dominant circumflex is diseased, LAD is diseased. You can see here the left main and circ look sketchy. You can see here the LAD is out. Not sure what the culprit is. Everything's still thick by echo, no Q waves, pretty good R wave progression. Send him over to us. Surgeons are not super pumped about this one either. Guy's got bad COPD because he's from Eastern Washington, still smokes the whole bit. So at this point, they said, hey, can you come take a look at this guy? We used mechanical circulatory support in here, ended up looking at the LAD first, again, not sure what the culprit was, started probing it, turns out it was probably a CTO, but are able to get guy 3 next to go down, as you can see on the panel on your left. And of course, the microcatheter won't go at that point. So what we do, wire cross gear won't go. We bury a microcatheter into the lesion as far as it'll go. Guy comes out, free wire the rest with a rotofloppy. 1.5 burr goes in, and there you go. So at that point, the IVUS goes in, and look at that. Nice little nodule there in the prox LAD back into the distal left main. 4.0 IVL balloon, able to take that after NC balloons didn't seem to go. Able to get a good angiographic result, as you can see there with a great MSA. So in conclusion, our calcified nodular lesions, they're becoming more frequent, right? Our comorbidities are going up. We're seeing increased calcific disease. Part of it is increased recognition. Part of it is comorbidity and probably increase in prevalence. We need tools to address these patients. Imaging can help identify these lesions and is at the key crux of helping figure out the best way to treat these patients. Our current calcium solutions have some limitations, but they continue to be necessary. So IVL is not the only tool in the bag. It's just a new tool in the bag, and it can certainly help us address these calcified nodule lesions. Thanks very much.
Thanks so much, Rob. Okay, so you'll recall, and Ajay, if you want to just narrate here, this is your index procedure, the OCT on the index procedure, which showed severe calcified nodule. We saw that distal lesion, that mid lesion as well. And so after hearing these presentations and thinking back on Ajay's initial case, what approach would you take to address nodular calcium if you were to face the patient that Ajay faced now? So maybe while people are polling there, we can talk a little bit about this. So obviously, we have the benefit of hindsight. And Ajay, maybe I'll start with you. In retrospect, you might have done something different. What would you have done differently? And is it changing what you do prospectively going forward now when you see cases?
Yeah, I think that the challenge with this this whole thing is I'm not certain that anything we would have done might have done it differently, because as you said, this is like a very rare case and you don't typically see this. The reason I wanted to show is not because it's rare, but to recognize that this can be a real issue. I do think, though, good modification of the nodule is super important, and OCT is probably going to be the only way to sort that out. It may be that NC balloons in an eruptive nodule, fracture the planes and you get good fracture at that point. It may be that you need the IVL. You may or may not use atherectomy. The whole thing is very much up in the air, and that's, I think, one of the reasons why we were all excited to be up here, because many things that we do right now in PCI, you can sort of see their algorithms and we know how to deal with it. You just have to think about the algorithms. There's not a good algorithm right now, and we need to generate the data to help sort that out. Some of that we're doing in conjunction with Akiko and her team and all of that, but I think it's going to be an area of keen and active interest.
I know we've talked a little bit about this, but maybe, Margaret, I'll ask you. So how would you summarize how you're seeing the different strengths and limitations of the various approaches, starting with NC balloon, atherectomy, the combination, IVL alone? How are you sort of in your mind sorting out which ones you're taking on for which strategies?
I think it's kind of an evolving psychology at the moment, I think. So for me, if I see a significant nodule, I'm not going to use a non-compliant balloon, and I'm not going to use an OPN balloon, because I just don't believe in pushing harder. It's just not sophisticated and it's not clever. And I think you're just going to cause hazard. Probably once you've put your stent in and then you're trying to post-dilate it, you're going to rupture the vessels. So I just wouldn't advocate that if you see significant nodularity. And then I think with IVL and atherectomy, I think, if you've got an uncrossable lesion, it's clear you need to use atherectomy at the beginning. But I'm thinking, as we delve into all these morphological aspects, I think there's going to be some cases where it's going to be clear we're going to need both. I think there's some cases where it maybe is going to be clear that we should avoid atherectomy. So I wonder whether around the eruptive area, that's where we get distal embolization, because there's thrombus around on the lesion. Whereas the thick fibrous cap ones, less likely to get dyslimalization. So I think I'm excited about it because I think we really are digging in to where which aspects of each technology is going to be helpful and hazardous, I think.
Yeah, I mean, I think, we really don't know what we don't know, and it's really still a black box. And that's why anytime we put up algorithms and all these other things, I mean, it's such an evolution. And I think that's why it's exciting to have new technology that takes us back to something that's been a problem for a long time. And it's fun to say, okay, now we have a couple options. Like, what's the best thing here? And, when we talk about high-risk PCI and all, people always want, oh, what's high risk? Really our job is pretty simple, whether it's high-risk PCI or not high-risk PCI, whatever you want to call it. It's to treat a lesion that has an indication for a patient who is having some form of symptoms and impact in their life. And, our job is to do it in the most safest and efficient way possible. And I think that's why, we've all done a lot of atherectomy, and we know it's not free, right? Nothing is. But IVL has changed that a little bit, and I think that's why I've been so excited about it and so excited about sort of seeing use patterns and best case use patterns for that, because at the end of the day, that's what I want, right? I want the safest, most efficient treatment strategy for my patient who's on the table. And it's going to be continuing to evolve. I mean, we're talking about writing a calcium document right now, and it's like all it can be is an expert consensus statement because, again, we're just at the front leading edge of figuring out best use patterns. So it'll be exciting to see.
Yeah, I mean, the one thing I'll add is, we are lucky enough to have CHIP fellows in our program, and when we stand in these cases and decide what the next step is and commit to it, and full disclosure, we don't know, as everyone has said. And so the one thing I'm mindful of is I'm trying, and I think we all are, to learn along the way. So if I, commit to a series of decisions and say, I think this is going to do it, I know the answer in terms of whether I'm happy with the result, because we always image on the back end. And so I think, trying to inform the result of your decisions by checking your work and making sure the stent expansion is adequate is the best thing to do. And I've gotten burned. I've gotten the places where the stent looks awful, the area's okay. And then to Margaret's point, I'm really terrified when I'm taking a 1-to-1 size balloon to 24 atmospheres in these lesions to try and get it to expand because I got it wrong up front, because they tend to have it, they have a tendency more than others to push through the artery wall. And next thing you're doing is you're putting an underexpanded papyrus in. And so getting it right up front, and I think to Margaret's point, being maybe my approach has been more generous with atherectomy, more generous with IVL, because there's not much you can do on the back end, and remediation strategy is not fun in any way, and it's potentially dangerous.
That's great comments. Gary?
I mean, we're all used to the concept that the quality of the acute result determines long-term outcome. And the better the acute result, the better the patient will do long-term. It's entirely possible that eruptive calcified nodules are the exception to the rule, because when they present with either in-stent restenosis or stent thrombosis, there's reintrusion of these eruptive calcified elements into the stent, whether it's caused by stent fracture or whether it's a biologic progression. I don't think we know, but this is probably the one exception where everything you can possibly do, the perfect acute result, may still be associated with procedural failure long-term because of the biology, the underlying biology of the eruptive calcified nodules. I think the non-eruptive calcified nodules follow the typical rule of good results predicate good long-term outcomes, but the eruptive ones are very different.
So Gary, are you not surprised then when you saw Ajay's case that such a short period of time later, after what looked like a really optimal PCI result, that most of us are not taking our patients back and re-imaging, of course. Are you not surprised then by what you saw in that case after?
No.
Oh, he's surprised.
No. I mean, I've seen the spectrum of people who have an eruptive calcified nodule who are stented, and they're back in a month looking much worse. So, I mean, I just think we have to not kid ourselves in thinking that if we have the perfect acute treatment of an eruptive calcified nodule, that it means that the patient is going to do as well long-term as if it were, say, garden variety calcium.
Yeah, and clearly we've seen that from the CAD3 data already. We saw that they had, both Kevin and Rob showed the slides that equivalent MSAs at the end of the procedure with calcified nodule or not, yet still a strong association with worse outcomes when you have those present there.
And we have to separate the calcified nodules, as Margaret alluded to, into two types. the eruptive ones, which are part of the acute coronary syndrome family of lesions, and the more stable non-eruptive ones that have an intact fibrous cap and think more in terms of either one or a collection of marbles.
Gary, before you step away, you and Akiko have looked at probably more core lab, IVUS, and OCT images than anybody. In my experience, the rare time I get acute stent fracture, it's almost always associated interprocedural with these. Thoughts on that incidence? Have you seen much of it?
Well, I mean, at least in the eruptive calcified nodule story, it's also related to hinge points in the coronary artery. Remember, eruptive calcified nodules occur at hinge points. Exactly why, I don't know, but they certainly do, and larger hinge points, and that's a predictor of stent fracture. So certainly acute stent fracture, I would agree with you. We don't quite understand the potential of long-term stent fracture, and I also think that the tendency of the stent manufacturers to make extremely thin strut, flexible, pliable stents. I mean, the engineering is marvelous, but maybe there are situations when that's counterproductive.
One thing that I've sort of learned to kind of simplify it a little bit, it goes back to a slide that Margaret showed, which was the arc of calcium associated with the nodule. Because there are cases where there's a nodule and there's not a lot of arc of calcium, and typically in those cases, what will happen is you'll expand on the opposite side, you'll push the nodule away, and you don't have to fracture the artery to expand your stent. But I think probably one of the mechanisms by which IVL would work specifically is not that it's going to modify the nodule itself, but the base where it's sort of tied to that arc could be fractured, and therefore it allows it to be, less strength to come back in. And I think that's an area where it's really important to study it, because the mechanism of all these things is different. Atherectomy is going to hopefully try to modify the nodule a little bit. That may engender a fracture when you dilate, but it's probably that base area that's important to smash.
And I think we've seen some data from Ziad Ali that's exactly the case, right? There have been fractures that have been identified at the basis. Margaret?
Yeah, it's interesting because I've started to pay more attention to that recently since we discussed and if you look the next time you image after you've used IVL or whatever for a nodule, that you'll see that where the plate joins the base at that junction, that's often where you get the fracture. I mean, it's complete anecdote, but certainly the cases I've started to look at once we've done that, I've noticed that, so it will be interesting to get more data on that.
One thing that we're taking as an absolute given for this discussion is that we're talking about imaging. So I suspect that there are probably members of the audience who do not necessarily image 100% of the time when they see calcified lesions. So what is the role of intravascular imaging? Is it 100% necessary for calcified lesions when you see stuff like this, or do you pick and choose?
Just real quick, I think it should be 100%, but we're also kidding ourselves because the imaging catheters du jour that people use will never cross these. So we are fortunate to have imaging catheters that will cross, and I think there's a necessity to get those types of catheters in your hands so that you can do it, because if you take, for instance, in your case, Rob, the eagle eye, no way is it going to make it anywhere near out of the left main. So it's great for us to say image, but what does that mean?
Yeah, I wasn't sure if we were going to say the word, but yes, the eagle eye. I'll look at that and I'm like, sure, let's drive that cipher right on down across the nodule and see how we can do it, yeah.
And you have to be committed, because that case I showed, I had to get the guide extension down to get the IVUS in.
Yeah.
So I had to get a balloon down, get the guide extension down, and then but for me it's worth it.
Yeah.
So I think you have to commit to the fact that you want to image to get the best outcome for the patient and use all the tools you need to do
I think
it.
that's the norm for these cases, that you need the guide extension to deliver the microcatheter, because as people know, the RX length and the support that you get in crossing any one of these intravascular devices is just so limited that it's going to be hard to deliver. Kevin, and then a comment from the audience.
Just to Margaret's point, I think the usual cadence of these cases is if you need to, atherectomy wire to roto or orbital to balloon to get an imaging catheter to then really plan the case at that point. And so, just because you can't get an IVUS down or an OCT down at the beginning of the case, it should be before you start to plan definitively what the stenting strategy is. And that stenting strategy is, have I modified the calcium enough that it's time to stent? And the imaging is the only way you're going to know.
Question from the audience or comment?
Thank you very much. One question, please. Are there any tips and tricks to control your wire bias toward the nodules? I mean, for example, using stiff versus soft rota wire.
Maybe we'll ask Margaret to take that, because you talked about that. Margaret, go ahead.
So you can change the wire that you use. I have to say, in my practice today, I just use rotofloppy for all my cases. So yeah, I've never been, I have to say, entirely convinced that it makes a huge amount of difference. I think one thing to become skilled at, though, is when you IVUS before you do atherectomy, particularly rotational atherectomy, pay attention to how the IVUS tracks the plaque, right? So watch where the IVUS catheter is and watch how it tracks the plaque. And if it's not sitting against the calcific plaque or nodule, then it's less likely to be effective. So, but sometimes you'll very clearly see it hug the path you want it to be, and then you're more confident you're going to get good modification. So yeah, so pay attention, and maybe that changes your decision what device you use. If you can't get good wire bias, maybe you have to change to either a different atherectomy device or IVL instead.
Did someone have another? One of you guys have
So
another
you can
comment?
also adjust your distal wire position and your guide angle of incidence of the guide too to try to affect that. But it's important. The imaging is super important to recognize. And Margaret and I did a live case for PCR, or case transmission to PCR, where you could nicely see that the imaging catheter was on the opposite side of the nodule. If that's the case, and you take a burr through there, you're not going to touch the nodule. So you're just going to take the burr down.
Yeah, thank you.
I'll just highlight that before the poll went off, that there had been really a movement, a shift from people choosing a sort of I think a diversity of things to really moving to 60% plus of the combination of IVL and atherectomy. Another question from the audience here.
Yes, sometimes you get a vessel where you have a nodule, a big nodule, but totally normal-looking vessel going around it. Do you approach those any differently?
I think that's the scenario that Ajay was sort of speaking about a little bit. Ajay, do you want to just sort of say what you...
Yeah, I mean, there's several things. One is that sometimes those are actually not flow limiting too. And so they don't always need to be treated. And recognizing the fact that when you treat it, the outcomes are suboptimal, you might not need to treat in some of those cases. Obviously, if they are significant and you do need to treat it, they may be ones that you don't necessarily need to cause a fracture at the base, but I think you have to image it first to sort that out.
It's also, I kind of wonder about that, because if you look at the data from Disrupt OCT sub-study, 94% have more than 180 degrees of calcium associated with them. So I think they are the rare cases where you don't have a lot of concentric calcium associated. Maybe we just aren't quite tuned in, in our practice to recognizing it. Certainly I was surprised when I saw that data, but when you start to pay attention, having seen that data, you start to see it.
Kevin, maybe I'll ask you. So we've talked about that we don't have a lot of data for these various things. What data are you most looking forward to seeing, or what data, if you could have data, what would you want to be produced to sort of guide this treatment?
Yeah, I think, we've talked about the various types, eruptive versus not, and I think understanding which device for which nodular entity is a tough thing. Interprocedurally, as I talked about, we struggle with this. And so, is it, one thing which I've tried to apply, I don't know if it's going to work, is we use a lot of atherectomy plus IVL, even if the IVL is deliverable, really to shave fracture, because there's often, these happen in large vessels, where, a small rotaburr to facilitate delivery, a couple runs orbital to shave and facilitate delivery, and then IVL to be able to modify the base, both near and deep. We've taken that strategy. Whether simple surrogate, do I get better MSAs than maybe rota alone, orbit alone, or shockwave alone would be helpful, because I think, Gary's point notwithstanding, if you leave the stent compressed, I worry more about it than if I can get a good MSA that's a circle, as opposed to one that doesn't have a good MSA that is indented.
Yeah, even though we know that having an acute result won't necessarily mean it will be perfect 6 months down the road, I think what we know for sure is that if you don't have a good acute result, it's definitely not going to look better over time. Rob, do you have a...
I just think to that point, the thing I struggle with, the more data that I see and the more imaging we do and the more we look at this, the thing that I struggle with the most with is, how do I know that I've changed my vascular compliance enough to implant a stent to get the kind of short and long-term results that we're talking about? So for example, short, focal, but thick calcified lesion, okay, we do have calcium scoring rules and things like that which can be helpful, but how many fractures do I need? Do I need one fracture? Do I need multiple fractures? In what and because that's going to really be important for if we try to do head-to-head, what are we actually looking at outside of just our long-term results? Is there anything acutely that we can look at? And we just don't have a measure of vascular compliance. So for example, I drill a vessel. It's a long calcified lesion. I'll go down with my imaging catheter afterwards. Some areas I'm going to have fractures. Okay, cool. That looks great. I think that's good. Some areas it's still thick, right? And that's going to be where I do my IVL. But again, how do I know when enough is enough? And that's the same idea of, do I NC balloon after I shockwave or not? Again, hard to know without some objective measure there. And I think that's where, moving forward, if there's some way for us to sort of start looking at that, that would be monster, for these types of lesions.
There's a question from the audience, and I also saw that you also had a question if you wanted to say it afterwards. So why don't he answered it already. Thank you. Okay, great.
So another question is how aggressive rotablation we can do in such patients, because his vessel is around 4 millimeter. So you use a 1.5 millimeter burr, it may not be adequate. So when you have a lot of calcium like that, why would not use a more aggressive burr, 1.75 maybe?
Someone want to take that on?
So in that case, I used 1.5 because it was so tight. Like, even to get the microcatheter through was so tight. I thought, so obviously you have the option then. You either go small burr, then upsize, small burr, then IVL, small burr, then cut, small burr, then NC. So you have all these options, obviously, to choose an individual case. I would use all of those in different situations. It just depends on each individual situation.
Yeah, I think then Margaret also spoke to that. I mean, that's the type of scenario where where orbital may have an advantage because you can get across, but it may not. We just don't know. It's just if your IVUS is on the opposite side and it's not going to get anywhere near it, then you're going to have to take a big burr.
You can also start to get a sense of what the next step is with intercurrent imaging. So, I've had cases where a 1.5 burr, 1.75 burr imaging catheter goes down, there's still 0.7 to 1 millimeter of calcium there. It's not time to stent. And that's you've got a nice open hole. That's a great application for IVL in those areas because it tends to work really nicely in large vessels with thick calcium. And so understanding what the imaging show you intra-case to plan your MEX maneuver, I get a lot of value of. I'd be interested if you guys are making similar decisions that way.
Yeah, and I think, just to follow on from the discussion about upsizing the burr, I think there's maybe a bit of an argument to use a combination of technology. It gives us better bang for our buck, because if we understand that we have the concentric associated nearly with all of our nodules, then to use the rotor or the orbital and then use the IVL, to me, you get two different modes of modification rather than just using the same but in a bigger size. So I certainly have moved towards that strategy, just because I feel like I'm doing something slightly different to the calcium, and I'm changing I'm reducing the volume, I'm fracturing it, and I'm increasing the compliance.
Mm-hmm. Yeah, and this gets back to that idea, if we're going to do complex lesions, our goal is to do it as safely and efficiently as possible, right? So I remember pre-IVL, I was a younger operator than I am now, but still doing the same cases. So we'd take a 1.5 burr down, great. NC balloon, angiosculpt, Wolverine, whatever, doesn't look great. I'm sitting there like, okay, well, a 7-inch guide here, all right, I can 1.75 burr, it's still looking kind of, we've all had those cases where you're like, come on, man, like, why is this not fractured? Why is this not doing okay? And then you'd be like, okay, gotta get my 2 burr down to 7 French, just got, and those days have, for the most part, gone away, because now I can throw an IVL balloon. It's pretty rare. If I've got a 1.5 burr across it, I can't get even a 4.0 IVL balloon down, as long as you're being sensible, like using buddy wires and guide extensions when needed, so, or wiggle, whatever you want. So I just think it has to do with being, the safety profile of getting these people efficiently treated as safe as possible.
So I want to talk a little bit about like some of the nuts and bolts of how you guys go through these procedures. Now, for me, I have what I call the fellows like an opening playbook for complex cases. It's always 7 French. It's always radial. It always starts with a trap liner in place and I always start with a microcatheter. And that's sort of almost every complicated case where the CT or calcium starts with that. So there's just there's this regimented sort of playbook. I want to ask you guys, what's your playbook? Some specific questions. How high do you feel comfortable on an NC balloon? What exact inflation pressure do you feel high going to? Sometimes, I've heard people say 24 on this line. I've heard 20. I've heard people go to 30. Is OPN going to change that for you? Just go through your playbook and some of the limits of what you'll press and what you won't press on, what you won't pass.
Yeah, it's funny. If we know the anatomy, we pretty much go up with a 7-inch guide with a trap liner, microcatheter wire, tip of the guide, turn it in, wire and go. It saves contrast, and so we set up the same way.
Yeah.
Our tolerance for high pressure inflation is, I think, a little bit related to the fact that we see a lot of patients with multi-layer ISR. So, in a resistant lesion, it's already been stented 30. I wish we could go higher. I think in a nodular or calcified lesion like we're talking about, I'm not excited to go over 14. I want to modify it and soften it and change the compliance, as Rob noted, before going high pressure, for predilation especially. And so I think, soften to modify is sort of the cadence. And going high pressure on these things before you change them is hazard prone, I believe.
Yeah. I mean, pre-IVL, you'd go in there, and I remember when, for example, Wolverine came out. They're like, hey, you're supposed to go to like 6 or 8, and you'd be at like 14. You're like, I don't know, man, it's not cracked yet, so I'm still going here. And it was the same thing, with an NC. What's your comfort level? I don't know, I'm at 24, and it's not doing its thing yet, so, I'm going to go up to 26. So, and I guess it's the same way I feel about OPN at the time, because I don't feel great about lasing de novo non-stented lesions, even more than doing these other things. That's just what we had to do. I got to tell you, though, it's pretty rare that I'm going to go above nominal pressure on an NC or whatever else now, because I just have other options. Like, I don't have to worry about that as much. Now, there are obviously times, right, where that's not going to be the case, especially with single layer, double layer ISR and stuff like that. But again, we sort of have other options, laser and things like that. But I just think the days of having to go to 24, 26 just because something won't expand are starting to kind of go away a little bit. Still some exceptions to that.
Thankfully.
But yeah, thankfully.
Margaret?
Yeah, my setup's the same. So I think if you get into complex case setup with all the support you can have, it will make the case more efficient psychologically. It's a much more pleasant experience not to have to go backwards to go forwards. Coming to the high pressure thing, that horrible feeling when you're up at high pressure and you want it to give, but you kind of don't want it to give at the same time, because then it gives and suddenly you've got a problem. So I hate that experience, I think, and I think if we can avoid it, then we should avoid it, and we now have technology that will help us avoid that. So I will go to the top end of the deflator when I need to, but I think if we don't have to do that, we shouldn't. I've had an experience in Europe, obviously, of using OPN, and it's a similar experience. You're going up and up and up and up, and it does give you another tool on the shelf, but for me, it's my last option if everything else has failed.
Yeah, I think just for variability of practice, almost, what I'll say is that it kind of depends on the type of nodular lesion we're talking about. For the truly balloon uncrossable ones, setup would be exactly the same as you described. There are definitely cases, though, where the vessel's open and there's nodular calcium that you see there, and you think you're going to do something differently. And for me, because I'm pretty comfortable using, orbital as an atherectomy strategy, a 6 French is reasonable. You can do it through a 6 French. You can do it through a guide extension as well. So there's, I think, a little bit of difference between the types of lesions that you'll see, and I'm sure you all would agree with that. And as far as going up, it really depends on the lesion. And to bring it to nodular, I fully agree. Those are the cases you feel uncomfortable about pushing it through the side of the wall and then having it release. But for non-nodular calcium type cases, I'm pretty routine in going to 24 atmospheres with an NC balloon sized 1-to-1 by imaging. And that's kind of the standard in our lab.
Mm-hmm. Great. Well, I think our time, if I'm right, is up. So it's been a really, really fantastic conversation. You've heard about the different modalities that you can use for calcium, and I think you've heard that there's a role for all of these modalities. You've heard about the central role of intracardiac imaging and how, this is something that requires just an expert consensus because we don't have really strong data to support it, and hope you've been provided that today. So thanks very much for joining.